Well, good morning and welcome to the annual Pomerantz Visiting Professorship. And this year we're very honored to have as our guest Dr. Bill Putnam. Before I introduce Dr. Putnam, I'd like to just say a few words about Dr. Pomerantz, in whom the lectureship is held to honor. Dr. Pomerantz was the head of thoracic surgery here at the University of Colorado and grew up in upstate New York. Was a star tennis player at Colgate before attending medical school at Rochester University. From there, he traveled south and did his surgical residency and his cardiothoracic training at Duke University. And from there was recruited to the University of Colorado by Dr. Van Eisman, who at that time was the chief of surgery at Denver Health, which was known as Denver General Hospital in that era. While in Denver, Dr. Pomerantz established a particular expertise in the treatment of mycobacterial diseases, initially tuberculosis, but then all variants of mycobacterial pathology, and in fact became the world's expert in the surgical treatment of these very difficult diseases. He established a very strong relationship between the University of Colorado and National Jewish Hospital, which continues today. Dr. Pomerantz went on to be the president of the Western Thoracic Surgical Association and the chair of the American Board of Thoracic Surgery. And today, he and his wife Peggy are enjoying life in Tucson, Arizona, in a retirement in which he plays golf at least 7 times a week. We're very honored to have Dr. Bill Putnam as our guest, as I mentioned, and I'd like to introduce you to Dr. Putnam. Dr. Putnam is also the chair of the American Board of Thoracic Surgery and is currently the medical director of Baptist MD Anderson Cancer Center in Jacksonville, Florida. There, he is also the chief of the section of thoracic surgery. Dr. Putnam is a native of North Carolina and attended undergraduate and medical school in Chapel Hill at UNC. His surgical training was at Johns Hopkins University and also at the University of Rochester. And during his surgical training, he took time out to do a fellowship at the National Cancer Institute. He completed his thoracic surgical training at Michigan in Ann Arbor. And from there was recruited to MD Anderson to begin his academic career. Dr. Putnam was a leader at MD Anderson in Houston, Texas, for about 16 years, during which he established himself as one of the premier thoracic surgeons in the country. His leadership skills were quickly recognized, and he was recruited to Vanderbilt to be the chair of thoracic surgery for 14 years, I believe, under which his leadership provided tremendous growth in the program at Vanderbilt, and it emerged as a truly outstanding program. His leadership was further recognized when he was recruited to Jacksonville into his current position, where he, as I mentioned, is the medical director at Baptist MD Anderson Cancer Center. And under Dr. Putnam's leadership, he has championed the provision of multidisciplinary cancer care, something we look forward to learning about this morning. So without further ado, I introduce you to Dr. Bill Putnam, who is our Pomerantz Visiting Professor this year.
Thank you, Dr. Fullerton. It's indeed my pleasure to be here today with you and deliver the 15th annual Pomerantz Lecture. I have had significant influence from the University of Colorado. I interacted with Dr. Pomerantz as a pup. He was an icon in thoracic surgery, and he was also chair of the American Board of Thoracic Surgery for between 97 and 99. And Dr. Pomerantz, you signed my first recertification certificate. How or why, I don't know, but thank you for that. It kept me going. Dr. Grover and I interacted when I was just a young faculty member at MD Anderson, was terribly impressed with his quality improvement activities through the National Surgery Quality Improvement Program, which he helped found, as well as our STS National Cardiac Surgery database and inspired me to do a similar type database within our MD Anderson Cancer Center. He was president of the STS 2006 to 2007. I've had a great privilege to work with Dave Fullerton, president of the STS and currently executive director of the American Board of Thoracic Surgery. Dave, thank you for your leadership and your guidance of our board. And finally, Dr. John Mitchell, who is chief of the Division of Thoracic Surgery at Colorado. He chairs our credentials committee for the American Board of Thoracic Surgery and also serves as our liaison to the American Board of Surgery. So to the University of Colorado, thank you for your influence and assistance to me. I'd like to talk today on the ways in which I have had significant help from so many to advance multidisciplinary cancer patient care here in Jacksonville, Florida. The objectives for this lecture are to summarize the role of multidisciplinary teams in improving cancer patient treatment outcomes, describe the rationale for this new hybrid clinical academic cancer center program model within a large regional health system, and finally, to explain the organization and impact of people, systems, and processes on advancing integrated cancer patient care. I have no disclosures. So I'd like to reflect today on a personal journey and the impact that various institutions, various people have had on my career and how this has influenced my concepts of providing multidisciplinary integrated cancer patient care. It's not just to have the conference or to have the conference note, but it's also to create the systems and processes by which we can surround that multidisciplinary process so that it can be sustainable and renewable as we progress. So after finishing at Chapel Hill, I went to Hopkins. During my research years, I went to the National Cancer Institute. I worked with Steve Rosenberg and Jack Roth, as well as many others. It was the first time that I had seen surgeons, medical oncologists, radiation oncologists get together in a big room, talk about complicated patients, and argue terribly one with the other. I mean, that free exchange of information was pretty remarkable to me at that time. Young and very influential. We talked about the early evaluation and comparison of surgical treatments, and a lot of very big operations were done. Now, this multidisciplinary cancer care teams were just that. They were teams, and teams tend to synergize strengths and decrease weaknesses. Stephen Ambrose, in his book, Band of Brothers, talked about Easy Company and how this group of men who were the first Army paratroopers trained together so intently, so completely that they knew each other by the way they walked. At nighttime, you could hear the footsteps and they would know who each other were. And they depended upon each other, independent in doing the job they had to do, interdependent in that they had to depend on others, and dependent on people to meet their supply and transportation needs. But together, they were very successful. These diverse teams create more and better solutions to complicated problems. And over the long term, groups make far better decisions than an individual would make. And as a group, you develop that special trust and confidence in each other. And in developing that trust and confidence, you have iterative knowledge and can apply that knowledge even better in the future. These multidisciplinary care teams can be developed in any specialty. As physicians, we commonly think of medical and surgical specialists, but the support clinical services, radiology, pathology, psychologists, as well as our team members, nurse navigators, and so forth, These individuals make up our multidisciplinary clinical team. We have our discussions within a multidisciplinary cancer conference. The purpose of this conference is to improve documentation, provide better communication, have a more timely diagnosis, and really to apply evidence-based treatment recommendations to the individual patient. Recently, there was a review from Roswell Park that looked at the impact of a thoracic multidisciplinary cancer conference on lung cancer outcomes. And they found that individuals who were presented in the conference compared to those who were not had a very significant increase in their overall median survival and their cancer-specific median survival. The conference allowed guideline compliance to increase to almost 94%, and treatment plans were changed in 41% of patients. In the United States and in some international programs, this may be considered a professional service. This paper out of Australia talked about the legal implications if professional services are provided. Issues of patient consent and privacy, duty of care, identification of physicians, because of the shared responsibility that such a cancer conference would imply as treatment recommendations were given. They also commented that dissenting views should be recorded and potentially discussed with the patient. I think this could be a very appropriate model for individuals that are billing for these services. However, in our system, our multidisciplinary cancer conference is an educational conference. It's open to all medical staff and patients' physicians. Privacy and confidentiality are emphasized, and it's educational in purpose. CME is provided. The purpose is to advise the treating physician. We have a note template that we use for each patient that is put into the chart, and there is also a disclaimer that this is not medicine by committee. The purpose of our conference is to stimulate the multidisciplinary and multi-specialty discussion, provide education to the attendees, and to serve as advisory to the patient's primary physician, because these results need to be tailored to the individual patient. Not only multidisciplinary teams are effective, but also single specialty teams. This recent paper examined the value of a high-risk committee for cardiac surgery decision-making and looked at 110 high-risk patients with an STS predicted rate of operative mortality of about 5.35%. Of those 110 patients, 62 were selected for surgery that had an operative mortality of only 4.6%, O to E ratio 0.86. 48% had no surgery recommended. Some of these had alternatives to surgery that were provided. So even in these high-risk patients, the outcomes were very good. And at 6 months, over 90% of those who underwent surgery were still alive. 78% of those patients who received alternatives to surgery were also alive. So this decision committee was able to be implemented. It did create consensus on the treatment that should be provided, and the outcomes that were demonstrated were very good. After my research years at the university, at the National Cancer Institute, I went to the University of Michigan for my thoracic surgery residency. I had an interest in general thoracic surgery, which I picked up at the NCI, and I was very intrigued with cardiovascular support and what techniques we could use to remove thoracic neoplasms. This was applied at my first job at the University of Texas MD Anderson Cancer Center in Houston, Texas. It was terrific. As a young surgeon, I was heartened by the comments of Dick Jesse, a head and neck surgeon. The early mantra at that time was that a surgeon may not know much about all factors of the disease, but may not be able to perform technically. He may, therefore, impress the world with his knowledge, but fail to impress the cancer. So for someone wanting to do big operations and apply novel surgical techniques, it was terrific. So we worked on a number of very large tumors using cardiopulmonary bypass support for resection. And my good friend and colleague, Ara Vaporjan, presented this work at the EACTS in September of 2001, shortly after 9/11, where we looked at the role of cardiopulmonary bypass in treating advanced thoracic malignancies. 21 procedures were reviewed. We did not include the IVC tumors in this group. Cardiac sarcomas, this is an angiosarcoma of the left atrium requiring a lobectomy, resection of the left atrial sidewall, and reconstruction. This is a patient with a recurrent malignant fibrous histiocytoma. As you can see, his left clavicle has been partially removed. The tumor has recurred. You can see where radiation has been given. When this patient was evaluated with MRI scans and CAT scans, it showed that this tumor invaded into the anterior aortic arch. So the operation required a brief period of circulatory arrest, patch closure of the area of the defect, and using a myocutaneous flap from the latissimus dorsi to cover the resulting chest wall defect. The patient did very well for about 3 or 4 years before succumbing to metastatic disease. The results were good, but they were not great. And it was a very limited series. Cardiopulmonary bypass was not required in all patients. I mentioned IVC tumors. This is a patient that had a primary mediastinal sarcoma coming off the aorta, right thoracotomy to mobilize it off the lung and the esophagus, and a left thoracotomy to remove the portion of the aorta that was replaced with an interposition graft. And the specimen is shown there. This patient had chemotherapy prior to surgery as an integral part of their treatment plan, and then surgery after that. This concept of resecting the unresectable tumor is often in the eye of the beholder, right? So bigger operations are certainly possible. Yes, one can do them, but is it the best thing for the patient? We were able to achieve excellent local control, yet patients would succumb to local recurrence or metastasis. This biological imperative reinforced the need for better adjuncts to surgery, as biology is a powerful force. So as part of that, we gathered together weekly for both a 1-hour discussion of complex thoracic cases, lung cancer and esophageal cancer, and also chest sarcomas, pulmonary metastasis, and sarcomas involving the chest wall. Very valuable and led to very effective treatments in some patients. This is an example of a patient from the late 80s, early 90s, where multidisciplinary care and induction chemotherapy was used for locally advanced, clinically stage 3A non-small cell lung cancer. This tumor was growing into the vena cava. Chemotherapy was given. The patient had lobectomy, resection, and vena cava patch reconstruction. Some of the chemotherapy that was provided was extraordinarily effective, as shown in this picture. And it yielded even better survival for patients treated with induction chemotherapy followed by surgery versus surgery alone. These are the early trials of induction therapy for stage 3A non-small cell lung cancer. For the statisticians in the group, obviously small studies, underpowered. However, there was significant difference between those that received induction therapy and those that had surgery alone. So promoting the value of multidisciplinary intervention for treatment of thoracic neoplasms. This long-term survival curve shows the continued value of perioperative chemotherapy plus surgery compared to those having surgery alone. So in contrast to Dr. Jesse, Mr. John Hunter, the preeminent British surgeon of his era, reflected on surgery being insufficient, that operations were a tacit acknowledgement of the insufficiency of surgery, thinking that surgeons should be more strategic in how they approached the disease state. Well, after almost 16 years in Houston, I had a great opportunity to start a new clinical department at the Vanderbilt University Medical Center in Nashville, Tennessee. This was a terrific phase of my life, and it sort of culminated with my time at Anderson, culminated in a review of organizational dynamics, organizational structure, leadership, and how we could apply this even better for our specialty. I would recommend Dr. John Cotter, who was the professor emeritus at the Harvard Business School. His book, Leading Change, was written in 2003 or 2004, but it outlines the 8 components of change management. And I will say that of these 8, it all starts with a sense of urgency, whether that is defined by you or that is defined by the institution. That sense of urgency is a critical first step in any change. And the need at Vanderbilt was really to create a Department of Thoracic Surgery, separate from the Department of Cardiac Surgery, to really advance the specialty component, general thoracic surgery, within an academic institution. I was very fortunate to have 3 colleagues, Eric Lambright, John Nesbitt, and Eric Grogan, which I recruited. We recruited a total of 4 physicians, and 2 PhD faculty were recruited to this new clinical department. Our thoracic surgery residency education program was revamped, and we had a clinic where we had multidisciplinary teams all together. So it was surgery, medical oncology, radiation oncology, and pulmonary medicine would all be physically co-located in the same clinic. We would run clinic in parallel. We did not see every patient together, but if we did need consultation by one of our colleagues, we would obtain that. And having them together in the same clinic was very effective. We also were able to track the results of our care over time. This quality improvement need was critical, and something that I had started at MD Anderson in Houston, and was able to take that same program to Vanderbilt. This thoracic surgery QI project was to collect data prospectively define the data, and collect the data concurrently with patient care. And the goal was quality improvement, risk stratification, and future clinical research. The points of decision were in the clinic, the OR, the wards, and in the offices. And the data that was collected was originally paper-based, but subsequently was electronic, internet-based, and tried to minimize the role of typing. So lots of drop-down menus, and typing was by exception. Here we have information on the operations that were done, and the discharge events that we tracked. We did not have any complications at Vanderbilt, by the way, following surgery. We did, however, have a number of postoperative events, and those events were tracked without blame. We discussed all the events in our conferences, and we collated them and used them for quality improvement. That conversation with our thoracic surgery team was invaluable in in promoting our program to high levels compared to national benchmark. This is a slide from 2013, from a quarter in 2013. We had done 743 operations over the running 12-month period, and we were ranked in the top 10 in the University Health System Consortium. And our observed to expected mortality for that 12-month running average was 0.53, an extraordinarily low number, and reflected, I think, the quality of care that we provided, but also the documentation and data that we had that would be able to appropriately risk stratify patients in the most appropriate means. So this national benchmarking concept, I thought, was a very important one to validate the work that we were doing compared to the work that was being done at a national level. So national benchmarks include NSQIP, the National Surgery Quality Improvement Program, the STS thoracic surgery, cardiac surgery, congenital cardiac surgery databases, our University Health System Consortium, as well as our National Cancer Database and our Commission on Cancer Responsibilities. Well, with those formative years, I had the opportunity to be considered for a challenge and a unique opportunity in Jacksonville, Florida, at the Baptist MD Anderson Cancer Center. So when I arrived, this is what I was faced, this is what I saw. And I said, "What is that?" They said, "That's a parking lot." I said, "I can see it's a parking lot." And it wasn't a very nice parking lot. It was cracks in it. They had an old house, an old warehouse, and some scraggly palm trees. But it encompassed 2 city blocks. It was very close to our downtown hospital, and that was going to be the future site of the Baptist MD Anderson Cancer Center. Now, why Jacksonville? Why Baptist Health? Well, cancer has a significant impact in Florida. We are growing at about twice the national average, 6.8% population growth projected over the next 5 years. However, new cancer cases are projected to grow 33% over the next 5 years, reflecting that 40%, the impact that 40% of men and women will be diagnosed with cancer during their lifetime. The general incidence of cancer in Florida is quite pronounced. And you can see that in that northeast quadrant where Jacksonville resides is ground zero for cancer impact in the state, reflecting a significant need for cancer care. Well, the environment to provide that care was also very conducive to business and to a diversified economy. I talked about the population growing more than normal. Residential growth is increasing concurrently. Unemployment was low compared to national averages. Median home prices were less than the national average. Cost of living, 91% of the average. And there is a tremendously friendly business environment with friendly government and low taxes. We were also fortunate to have 2 Navy bases to anchor here in Jacksonville, our Mayport Naval Port and our Jacksonville Naval Air Station. Baptist Health was the largest health system in the region. Baptist Health is a locally owned, locally governed, community-focused, faith-based, not-for-profit organization committed to meeting the community's needs. This is a comprehensive health system. 5 hospitals, soon to be 6, multiple freestanding emergency rooms. And as you can see in the map that's shown with the hospitals highlighted in red, there are a number of blue dots. Those blue dots represent primary care offices under the umbrella of the Baptist Health System. There are over 70 primary care offices at this point, over 170 primary care physicians that are distributed well within our region that has a significantly high cancer growth rate predicted. So to have a primary care network under the umbrella of the Baptist Health System really creates a great model for care organization at a very large ACO or CIN level, which we are evaluating. The system itself, as I explored it, was a great system, wonderfully financially managed, a Standard & Poor AA rated with a stable outlook, a great number of days of cash on hand, with a focus on quality and safety. Today, all hospitals are Leapfrog Grade A, and you can see that the hospital-acquired infections over the last 5 years have dropped precipitously. As well, Medicare 30-day readmission rates are down, lower than the national averages, and we have implemented an enhanced recovery after surgery program in all major surgical specialties. The challenge in Jacksonville is that there were multiple small independent oncology practices, some single specialty oncology practices, inconsistent coordination and integration of care. Patients had to travel long distances, and a component of entrepreneurial medicine, which may not have all consistently had the patient's interest at the highest level. So there was an urgent need to provide better cancer care. A partnership needed to be created between the Baptist Health and MD Anderson. A full-time faculty is envisioned. An employed physician practice model was implemented with a focus on patients with known or suspected cancer. And this multidisciplinary integrated clinical team approach would be applied locally and in coordination with MD Anderson. So in order to provide this multidisciplinary care to a broader and more global footprint, MD Anderson Houston created the Cancer Network, which is a global system for more integrated cancer care and clinical research. And you can see in the black dots are sister institutions, the red dots are partners, and the blue dots are affiliated type programs. In the United States, there are 4 partners. You have the Cooper MD Anderson Cancer Center in Camden, New Jersey, the Baptist MD Anderson Cancer Center in Jacksonville. You have the Banner MD Anderson Cancer Center in Phoenix, and the Scripps MD Anderson Cancer Center in La Jolla. There are 2 programs within the state of Texas that are components of the University of Texas system, 4 partners, as I described, outside the state of Texas. So we wanted to have cancer care that was integrated, so guidelines, protocols, pathways, quality oversight, benchmarking, physician education, integration with MD Anderson to include prevention, screening, survivorship, and scholarly activities, which would also include novel cancer therapies. So in this environment, they needed a medical director with an overarching philosophy of making cancer history. Critical need for infrastructure, multidisciplinary care, clinical investigations, and quality outcomes. However, there was no school of medicine or university affiliation. This was going to be private, and being on the gown side of the town-gown relationship, I was a little bit concerned about that and reflected a bit on the comments that Dr. Ray Stantz remarked to Dr. Peter Venkman in Ghostbusters when they left the university.
Personally, I like the university. They gave us money and facilities. We didn't have to produce anything. You've never been out of college. You don't know what it's like out there. I've worked in the private sector. They expect results.
So they do expect results out of these individuals that they are recruiting. And the results were reflected in our goals, which was to replicate the MD Anderson Cancer Center, to integrate clinical care internally and with MD Anderson, ensure even better patient care that we could measure, both decreasing morbidity and mortality, decreasing the impact of cancer, improving survival, enhancing satisfaction, and advancing knowledge. Our multidisciplinary care team is now well established with multiple medical and surgical specialists, as well as many other team members. I think it's important for you to understand the organizational structure of our cancer program as we apply these care concepts to our patients. I work in a dyad model. As a medical director, I have an administrator to facilitate the administrative activities, essentially a COO. We are a physician-led, professionally managed healthcare organization, cancer center. I report to the chief physician executive. All physicians and all clinical services are under my umbrella. We mimic the structure at MD Anderson, Houston, Texas, with divisions of surgery, cancer medicine, and radiation oncology. And we needed to recruit faculty to accomplish these goals. So we tried to engage the local physician. There were some challenges, a bit of inertia, independent, established practice models, and a change in compensation models from fee-for-service private practice into an employed physician model. So to recruit the faculty, I looked at 4 components: technical expertise, emotional intelligence, coachability, and passion. Technical expertise gets you in the door, but the emotional intelligence, how you interact with others, coachability, how you take direction and guidance, how you reflect on your internal activities, and the passion or drive that you have is critical to the best faculty being recruited. Daniel Pink, in his book Drive, talks about extrinsic and intrinsic motivations. Yes, if people work, they do expect to be valued for that. One value system is a salary. However, for highly creative, intelligent people, autonomy, mastery of their discipline, and purpose are key to their continued personal and professional development. And there is no greater purpose than making cancer history. So there are multiple interdependent ways to align objectives, compensation with the base salary, stewardship metrics, and team awards are needed. We use national benchmarks for salary-specific recommendations. The stewardship metrics are shown here. Once you achieve a certain level of work RVUs, the 50th percentile, these metrics, which we measure, are tracked and used for a stewardship award. Importantly, we have all documents dictated and signed within 2 working days. This is weighted at 40%. And yes, we have been able to achieve that. Faculty planning, personal goals, and division-specific goals are also included, not only to recognize the individual, but to facilitate an integration of team and institutional objectives as well. The team goals validate the care that our patients seek. We want to build team cohesion. So the division award are the numbers of new patients and consultations that are provided. The Anderson Award is the growth in analytic and non-analytic cancer patients. Our patient satisfaction needs to be at the highest level. On March the 3rd, I was struck by we had more than 100 patients with 108 giving us perfect scores and only 1 with a 9/10. Like Mary Poppins, practically perfect in every way. So our patients reflect not only on the physicians, but also registration, parking, cleanliness, anything that impacts their visit. So I was very proud of this result. We also provide oversight to our faculty in order to create the ways in which we can continue to sustain and renew our models of care. So quality improvement, faculty planning, a credo, conflict of interest and commitment management, as well as development of a center for patient and professional advocacy. We've implemented quality improvement in a number of ways NSQIP was not here before Baptist MD Anderson arrived. That was one of my requests to implement this, as well as the STS thoracic surgery database. We have applied for and have finished our site visit for COPI, for medical oncology, radiation oncology with APEX, as well as our cancer network, QI, and metrics reporting. Our faculty really need to accomplish personal and professional goals. We don't have faculty reviews. We do have planning and development, which emphasize accomplishments, having the faculty do even more of what they want to do. So the faculty can set their personal goals in coordination with the division head, and will have at least one touch base with the division head annually. This is repeated every year. To facilitate professional behaviors, we have a credo. A credo is not a code of conduct. It's really a statement. I believe, I will. And these credo behaviors are renewed and signed annually. They are aligned with very much with our core values. Professional behaviors, to just expand on that, professional behaviors really create the foundation for patient and coworker safety and quality outcomes. They drive quality, communication, enhance retention, decrease burnout, and allow physicians to reduce medical errors and legal risk because they have their colleagues, their team members, their nurses, their scrub techs, their circulating nurses talk to them and give them information that they can use to provide better patient care. We have a conflict of interest and commitment management policy. Conflicts of interest are financial. Conflicts of commitment are time and effort. And they have to be balanced respectfully to the physician and to the institution. This policy is used. If people will fill this out every year, they'll disclose annually or upon a change. I have a separate conflict of interest and commitment committee to review all disclosures. If needed, a management plan and approval will be required, and annual audits are done. Now, this is important because drug companies, other entities will pay money to physicians for certain certain activities. This was a recent paper looking at industry payments to physician directors of National Cancer Institute designated cancer centers. And you can see that non-research payments and research payments affected a reasonable number of these individuals. And the question is, are those individuals going to be biased because of these payments? The authors just raised the question of whether industry payments to directors of publicly supported institutions, such as NCI designated cancer centers, does that serve the patients, serve the public's interest? Does it serve the patient's interest? So management of conflicts of interest and commitment are required and important to ensure optimal patient safety, trust, and confidence in the process. These professional behaviors promote a team culture of safety, and it is all about safety. So to promote these professional behaviors, we have aligned with the Vanderbilt Center for Patient and Professional Advocacy, which is an evidence-based program which provides both education to physician as well as tracking of patient complaints and coworker observations of unprofessional behaviors. And this is really to help guide physicians in their journey as they mature professionally. There is a gradated system to promote reliability, and this gradated system of increasing accountability if there is repetitive unprofessional behaviors is implemented. The vast majority of doctors have no issues with professionalism, nor with professional behaviors. A small number of physicians may. Patients always observe care delivery, and we know that a small portion of doctors are responsible for the largest number of malpractice risk. In a national survey, you can see that almost 60% of malpractice expense is related to the activities of about 5% of doctors. And the majority of physicians will not have any risk because they have exhibited professional behaviors at multiple states. But the unprofessional behaviors does create an issue. Bill Cooper at Vanderbilt looked at surgeons who had patient complaints and compared the complaint rate with complications, and found that surgeons who were in the top 25% of patient complaints had almost a 14% higher risk of complications as a consequence of their operations. So physicians who receive patient complaints at the highest levels did not have the best outcomes. If these behaviors could be changed or managed in some fashion, it would potentially save over 356,000 complications a year, a sizable number. Coworkers also observe care, and our close relations, professional relations with our nursing teams, our administrative colleagues, our assistants and staff in the clinic really are important as well to engage, because we have to work as a team with these individuals. So coworkers have real-time work experiences. If there is a problem, it allows professionals to reflect, and we get data points where we can identify patterns which may be present. Again, this helps to monitor and maintain the safety culture. We further enhance behaviors by the physical environment within which our physicians work and in which our patients receive care. Our goal was to create a healing environment within the Baptist MD Anderson Cancer Center. This healing environment is done in this building. We opened in September of 2018, 9 stories, all treatment, subspecialty care, everything except for inpatient care is done in this building. We have 50 beds in our downtown hospital, which is about 200 yards from this building. In this building, we have 60 infusion stations, as well as significant numbers of diagnostic and nuclear medicine facilities. We have over 600 original works of art, and these were selected by an art committee. We have 5 major art pieces, and these art pieces are there for our patients and for our staff to really reflect on the intangible values that we all have as people. And creating this model, this healing environment for our patients, for our staff, really takes grade A people and brings them to a grade A+ level. And our team does extraordinarily well. And it has been validated by the patient's confidence in us. We took care of over 50,000 patients last year. We are currently ranked number 5 in the state of Texas from nothing 5 years ago. And we have used our model to great advantage for our community and to great advantage for our patients' care and their families' care as well. We've created a sustainable model that has met the needs of this community and created a foundation for future progress. Our future plans will be geographical expansion within our system to implement a precision health not only in oncology, but also primary care with polypharmacy and pediatrics. Our cellular therapy program will be instituted later this year, and we will embark upon graduate medical education programs as well. So these last 5 years have been very important, and I wanted to show this brief video to you. Our patients and their families have been warmly embraced. We have beautiful, open and airy infusion centers, wonderful physical location, meeting the needs of the community. The past 5 years have demonstrated the commitment of our Baptist health system to provide even better cancer care in our community and beyond. This understanding has provided our community with the opportunity of a lifetime. And for all of us at Baptist MD Anderson Cancer Center, we have gone from the vision to the reality. Our cancer program currently ranks in the top 5 programs in the state of Florida. And that recognition truly validates the need for this special type of multidisciplinary care. And we continue to have a great impact on cancer care in the southeastern United States. It has truly been our privilege. The impact that we have had on our patients and our community has been very significant, just as the impact that the University of Colorado has had on the patients and on the citizens within the state of Colorado. And I think we can all reflect on the impact that Dr. Pomerantz has had on all of us. My dad died last year, and this was one of his favorite poems. It talked a bag of tools. Isn't it strange that princes and kings and clowns that caper in sawdust rings and common people like you and me are builders for eternity? Each is given a list of rules, a shapeless mass, a bag of tools, and each must fashion ere life is flown a stumbling block or a stepping stone. We've all been helped by so many in our careers. I'm very grateful for that. I'm very grateful for Dr. Pomerantz and the legacy that he has provided to the University of Colorado. And it has been my privilege to present the 15th annual Pomerantz Lecture. Thank you.
So, Dr. Putnam, let me first be the first one to congratulate you on such a wonderful talk, and hearing your story and all the different phases that you've been through. I think all of us, all of the faculty here at the University of Colorado have experienced similar pieces. And so, certainly I was listening to, the Johns Hopkins and going to the NCI and, fellowship training and multidisciplinary care, and many different points during your lecture really touched me. My question to you, and it is so obvious to you and to me and to many other people that the only way to get taken care of if you have a cancer is to go to an institution with multidisciplinary care.
Yep.
And your numbers, 41% change in, the plan. You didn't show your survival rates, but we have data in pancreas cancers, in liver cancer, that if you come to our multidisciplinary clinic, you have twice the 5-year survival rate that, say, the rest of the state of Colorado has. But we grew a lot, we doubled, we tripled, but then you reach an asymptote where, you're just kind of at steady state. And it amazes me that there's still a significant portion of people who go to the one doctor, whatever that one doctor says they do, and that's the end of it. How do you convince the public to change in that fashion?
Hard question to answer. I do think that that it's best to provide care. Medicine, like politics, is best done locally. So providing care to the patient in their community is always good. Part of the reason that the Cancer Network exists really is to provide that level of multidisciplinary cancer care to citizens within the United States and globally. However, only 10 to 15% of care is delivered at university affiliated or medical school, medical college affiliated hospitals. So the majority of care in this country is still done at a local level. My interest in this position and in this program was that we'd be able to provide a level of cancer care, modern state-of-the-art cancer care in a community with a critical need. Now we have got great doctors in Jacksonville, don't get me wrong. However, the coordination of care is really essential for improved outcomes. And that's the secret sauce. The secret sauce is not that secret, right? So if you can have people talking to get physicians talking together, putting the patient's interest paramount, then you're going to have better outcomes over the long term.
Yeah. And I do think that it's the entrepreneurship of medicine that interferes with always doing the right thing by your patient. And, unfortunately, I see that too often.
Our health system discussion would take longer than the few minutes we have remaining, but something that will affect all of us. And we all need to work toward even better care for our patients.
And again, thank you so much for that wonderful talk. Really enjoyed it. Thank you.
So we have time for perhaps one more question. And John Mitchell, who's the section head for thoracic surgery here, has posted a question on the chat, and he was interested to know your thoughts on how the multidisciplinary program that you've established has been received in the medical community, as well as by patients there in your area.
I think it's been received positively. It is a change in how in the standard practice in our community. So all change is viewed a little suspiciously early on. However, patients and families get it. I mean, they understand it, and they are self-referred, they are self-selected to come to visit with us. So patients do have choices. They do think, they do look at the internet, they do compare and contrast. So I think for our patients and our community, it's been very warmly received. And I think that as we continue to progress, as we continue to engage with our colleagues in the community, I think it's only going to get better. So but that requires communication, and we've been very, very focused on ensuring that communication with our patients and their families, with their referring physicians, with their primary physician, and with their healthcare team is done at the highest level.
Terrific. Well, Bill, thank you very much for an outstanding and stimulating presentation. It's extremely well received, and I know I learned a great deal. I think all of us did. So thank you very much.
Thank you. My privilege.
Well, we'll have a short break here, and then we'll have some case presentations for Dr. Putnam. And for anyone that would like to join us, please let me know. I'll make sure that you've got the Zoom link. We've got some cases that we want to present to him and find out where we could have done better. So, Bill, thank you once again. It's been a terrific having you as the Pomerantz lecturer, and I sincerely appreciate the terrific talk you gave.
Thank you, Dr. Fullerton.
Thank
you, team. Hope you folks have a great rest of the day. Thank you.
Right.